You're listening to the Physio Matters podcast in association with rehabmypatient.com, and this is session 86. Welcome back to Physio Matters. I'm still Jack Chu, and we are fast approaching that 100 podcast mark. We could have cheated. We could have added bonus episodes and other podcasts into that, but no, when we do get to 100, it's 100 consecutive months of Physio Matters clinical content. And so we're not quite there yet. Episode 86. Thanks for those that have followed along, and check out our back catalogue if you haven't. Now, we've got a bit of news first before we get stuck into the podcast, although most of this is now visited on a daily basis now on Chewing It Over, 12:30 till 1 o'clock on social media. That's our daily show midweek on weekdays. And so do check that out if you want to keep up to date with all things as they happen, because there's lots of cool stuff happening now, you can imagine, in digital media and education. We even have friends of ours, Emma Brockwell and Tom Jessen, have got books out even. And so our network is now full of esteemed authors, which is brilliant. So do check that out if you haven't already. Tom's book on A Clinician's Guide to Sciatica is fantastic. And Emma's book, Why Did No One Tell Me?, is about women's health, and especially useful for therapists and their patients to understand as to how to best move forward with all things pelvic health. Talking about pelvic health, we have Therapy Live pelvic health show for MSK generalists and pelvic health specialists coming up on the 6th of March. If you haven't got your ticket already, then snap up the last few. That's going to be absolutely box office. We've got sessions such as pelvic stress fracture, pelvic tendinopathy, but also then some more specifics on incontinence, men's health, other variables such as then accessing access for women to participation in sport and exercise. We've then got all sorts of different pieces, including some business variables, setting up pelvic health services in your facility. So it's going to be really nice and wide reaching, but also really, as ever, keeping the standards high for in Therapy Live spirit. We've then got some news with regards to Physio Matters Plus, thanks to those that are members there. The price, the only way you can lock in your price, because that's going to be varying in time, is to be a member and stay a member, and then your price that you come in on is your price forever. Okay, but we are making a bespoke platform. We've been sort of bodging and using different tools to deliver the content that we have on there. All the Therapy Live content from past and future is all going on there. All the exclusive premium work that we do on Physio Matters goes in there for a nominal fee a month without a contract. But we're creating a bespoke site that's going to be ready for March. And so if you want to get your price and lock that in, then you need to move quickly, because as that goes up, then we don't then carry that up. We don't price increase any of our existing members. So we're supporting those that support us early, and we even lifted in the founding members, as you guys might have known. So if you're wanting that price and sticking to that price, then please do stick around. And we've got exciting bespoke news coming soon. Final bit from me on news is that we are going to be, we've got our hands on a couple of hundred units of, imagine a digital dynamometer that's also an accelerometer, also a digital goniometer at £300 that we're going to be able to get you in March. And that is us getting our hands on it. And we really want to get those units to our listeners. It's going to be really exclusive. Details will come in the next couple of weeks. Keep an eye on social media for when that happens. But if you're interested in that and you're listening to this, it's the first time we've mentioned it, get in touch with us on social media, drop us a message, a DM, an email. We can get you on the list and you can be the first people to hear, because they're going to get snapped up quickly. So if you're interested in that and you're wanting to give that feedback to patients, that objective feedback that you can't always trust, the sort of, oh, that feels a bit weaker than last week or a bit stronger than last week, etc., then generally speaking, that's what people are wanting. That's what patients are loving. Then we're going to have that opportunity for you while stocks last, right? So we've managed to get that. We want to get it to listeners, but just get in touch with us if you want access to that. Huge thanks to Rehab My Patient for supporting this episode and sponsoring the podcast again. They're offering NHS trusts extended licenses during COVID so that they can use their facility of exercise prescription as well as then tele-rehab. We've also then got WhatsApp and SMS integration, so you can get your patients compliant in that direction, but also use rehabmypatient.com/physiomatters for a 3-month free trial, no contract, no obligation, no credit card details. They are the best in the game, and that's why we're proud to work with them. So that's enough from me. Today's episode is with Jo Gibson, a returning guest, but Jim set us the task of using the shoulder as a reference point for the complexities and challenges that we face in MSK practice. How important is structure? When is it important? How do we make sure the pendulum doesn't swing too far? How should evidence inform policy? Sometimes do we get too carried away with anecdotes? Sometimes do we get too carried away with empiricism? We explore all of it. Me and Jo have a really interesting conversation rather than an interview about those topics. And as ever, she showed herself to be one of the best thinkers in the game on some of the biggest issues of our time. And also, as a shoulder specialist, we were able to tether that to some shoulder-based examples. Hope you enjoy it. Thanks a lot for listening. I'll see you at the other side. I'm delighted to be here today with Jo Gibson, a returning guest to Physio Matters. I didn't scare her off last time. We've also worked an awful lot together since then, really. And we were just reflecting on those days. It's a number of years ago now that she was on Physio Matters to talk about the traumatic shoulder. No, it wasn't even traumatic, was it? It was unstable shoulder. Hugely popular episode. And so as if I wasn't already in love with her work before that, since then, of course, we've worked on a few things, kindly spoke at the Big R's conference, and has also started to move some education, well known for her work around the shoulder, but also the underpinnings that are under Jo's teaching there were always around the sensible and judicious use of the biopsychosocial model, understanding where to put your clinical reasoning at the heart of your care to make sure we don't just narrowly aspire to ever complex algorithms. And so as many of our listeners are, I am a massive and continue to be a massive fan of her work. Jack March has been scheming and putting some podcasts together for this year's plan. And one of the things he wanted us to do was to try to visit some of the big picture topics we've been talking about with Jo and others over the recent years, of how these things inform policy and practice, how these can sometimes really be the complex grey area decisions. But then also with Jo being the shoulder specialist she is, we're going to use shoulder-based examples to sometimes then get us back to that real politic almost of what happens in practice, the decisions that need to be made and the consequences downstream of bad behaviors. So that's a hell of an introduction, but it kind of needs it because we're going to hopefully wade through some fairly complex subject matter, but make it as clinically relevant as we can. Welcome back, Jo Gibson.
Hello, Jack. What an introduction. I'm a bit scared now if that's what we're talking about, but it's really lovely to be back here again. Thanks for asking.
Yeah, you promised that is what you signed up for. Let's just get consent out of the way. I know I've made it probably sound fancier than it is, but that's what we're going to go for.
Well, we'll just blame the other Jack if it all gets too hard.
Absolutely. I've already put that excuse in play, haven't I?
Yeah, so, absolutely.
In case there's a couple of people out of our tens of thousands that listen that might not have heard of you, just tell people a quick bio introduction, if you would.
My name is Jo Gibson. I work as a clinical specialist physiotherapist at the Liverpool Upper Limb Unit and have done since 1995. And I also work in private practice as a consultant physio, but essentially all my practice is with patients with shoulder pain or instability.
Fantastic. No, thank you very much. And so the best place I really want to jump in is on this notion, as I've described it, where you well known as a shoulder specialist, but also always kept your hand in clinical practice when many are otherwise been pulled narrowly into research or narrowly into teaching. You've managed to keep this portfolio career going. Can't have been by accident. And therefore, what is it about that seems to really want you to keep those your feet in those foundations?
Oh, that's such a great question. I think I always thought I would go down the research line. And early in my career, when my husband was working away at sea and I had lots of time on my own before kids, the reality was there was just no provision to do that in the NHS at all. And so anything that I produced with the team was ostensibly done in my own time. But I was really desperate to champion physio because at that time there weren't a huge amount of specialists. I had mixed responses when I went to some of the medical conferences to speak with Prof, who I worked very closely with. And I just kind of really wanted to give us some validity and get them to take us seriously. And that's why I did a few projects early on, which kind of got people to take notice and see what could be achieved if people work very much as a team. And then it would have been a very natural progression to kind of go down the master's, which I did do, and then the PhD route. But to be honest, Jack, I just love treating patients, and I've just, the clinical thing is what makes me tick. And I love having ideas, and I kind of managed to, with my medical colleagues, get industry to fund some fellowships, physiotherapy fellowships, that finally allowed people to do some clinical based research, and also be physiotherapists. So I kind of managed to create the job for some other people that I'd quite liked myself earlier in my career. But I think I've just accepted that I like having the ideas. I like seeing what's going on in the evidence and seeing how it can make things better, or the journey better for patients, and surrounding myself with a team of fantastically enthusiastic, positive people, some of who are much better completer finishers than me, to take those things to their fruition. And built up links with Hope University as well, where we've got the fabulous OMID Professor Kayat, who again, we have a big influence in informing research projects. So to me, it's that collaboration, making it clinically real and answering the questions that really challenge me as a clinician. And so I guess that's it. Every time I got to the point I was going to step away from clinical practice, I kind of bailed, because that's where my heart is, and that's where I kind of want to make the difference.
Yeah, it's been said a lot of times on this show by researchers that one of the things that drew them there is that there's just so many questions emerged, and I just felt like I needed to pursue them. I feel like the same answer seems to emerge when I ask you that question, either over a beer and a glass of wine or here, is that it's actually the same phenomena that did that. Clinical practice brings its questions, and that one of the ways to answer that isn't always by wielding statistics. It's about getting into the nitty-gritty of clinical reasoning and applying that to a number of different patients. In this case, of course, mainly on the shoulder. But as you've proven in recent years through work with us and beyond, is that these things apply far beyond any body part. So I wanted to just try and take us to a bit of a point of history, I guess, in terms of what you perceive as being the key paradigm shifts, or the ways in which things have swung in different ways. People talk of spectrums and pendulums and all that sort of stuff. I just wondered what you feel that, especially in context of the conversation we're going to be having about things between general and specific, between structure and top-down neurology, all those sorts of things. I just wondered, what do you feel are the, especially over the last, say, 10, 15 years, what do you feel are the big ascendant conversations that have been?
Oh, I just think that the whole kind of focus, if you like, or the light shining on what matters, has gone completely away from the biomedical, almost to, we don't need to worry about that anymore, far more in that communication and person-centered domain. And of course, those things are important. But when I think back to the start of my career, when I remember as part of my MACP placement, writing down all the things an AP on C5-6 did. And I really believed it, Jack. It did some amazing things. And I did my scapular setting courses, and I look back, and did patients get better because it was natural history? I was in a specialist center. Patients that had symptoms for several years still got better. But then when I reflect back, when I look now at the things that made the difference, there's no doubt that communication, where the focus is now, was absolutely pivotal, and is always something that's been massively important to me. But then I think also, when I look at the spectrum and how it has, that pendulum, if you like, has swung, I think it's not forgetting that as clinicians, we need a structure. So with that swing to that psychosocial perspective, and it being all about communication, that actually can be quite tough, I think, in terms of, okay, well, where does that leave me as a clinician in terms of what I actually should be doing? But yeah, massive shift away from the biomedical. I remember doing a book about all the special tests and proudly giving it to the team so they'd know all the tests they should be doing in clusters. And now I just think, oh, Jo, how embarrassing. I just hope nobody's got a copy. But at the time, it was like where the focus was.
Yeah, you could get yourself, someone dusts off an old course copy that you wouldn't sign off on now, and they think that will detect you. I think one of the things that's interesting, and one of the reasons why you're such a perfect guest for a show like this, was kind of trying to come through the middle on this, is that for a lot of low back pain specialists, for example, you can understand, unless they are working, say, out of an A&E department, and even if they're working in primary care, whereby they're keeping on mindful of the serious and the red flag style of that conversation, which we've covered plenty, you are in a situation where, in that instance, both in treatment in clinic, but also beyond into research, it is that the structures increasingly felt like they they mattered less and less. Now, Tom Jesson's got a new book out tomorrow, by the way, and I just had him on Chewing It Over today on my daily show. And he was he's sort of making a case for the periphery in those instances. But let's just say when someone say special interest has been in axial low back pain, you can so imagine why they would overindulge that. But then transferred across the body by just inferring that, look at all these imaging studies that have shown that you've got asymptomatics with these pathologies and stuff, that over time, amongst a certain cohort, including people that have had great platform to share those things on influence on social media, means that you've ended up sometimes losing out on some of the real specifics where it really does matter. And whilst me and you have never been ones to say that clinical practice across the board, if you took the mean average, the pendulum swung far, because I think in some cases it hasn't swung far enough. But on the influential, noisy side of things, there does seem to be an ascendancy to be dismissive of anatomy, physiology, some of the key things that are going on that really do matter. And in the shoulder relative to the lower back, that's somewhere that it's far more serious in many ways if they get missed. Do you think the body part related aspects of people's specialisms and their rhetoric, do you think that matters as much as I'm suggesting?
Do you know what? I think there's been a couple of absolutely fantastic editorials, well, probably 2 or 3 actually, the Carnero, the Lynn, and obviously Jeremy's with Peter Sullivan, kind of looking at MSK problems afresh. But I think there's a kind of caveat when you look at translating those different things in terms of rule out red flags, make sure there's nothing worrying, hear the patient's story, embrace patient or person-centered communication, educate them in an effective way in the individual's context and the necessary lifestyle advice and get them active. I have a real sympathy with that. And there's no doubt if you look at 70 to 80% of first-time non-traumatic shoulder pain that presents in primary care. The evidence suggests if you just left them for between 3 and 6 months, half would get better anyway. And there's absolutely no doubt a cohort that is well reflected by exactly the same cohorts in the low back pain. And to kind of separate those atraumatic MSK pains out in terms of those key principles obviously doesn't make sense. But I think we're in real danger of saying it's all about lifestyle, it's all about comorbidities, it's all about losing weight, getting healthy and stopping smoking, because I see a whole gambit of fit, healthy people who go to the gym who come with non-traumatic shoulder pain. People who don't necessarily fit that thing. So I think if we can be specific about who we're talking about, then actually that's quite empowering in terms of, if you like, some of the emerging evidence on what is best practice for those groups frees us up for the people that need more time. But I think the thing with all these models that's so important is having that knowledge base that allows you to know that, yes, that's an atraumatic shoulder pain that I can safely say those are the things that I need to prioritize. And it's having that knowledge base of knowing when actually you need to be more alert, not just about red flags, but other things that might need investigation or importantly impact how you set patients' expectations. And I love Rachel Chester's work. And I mean, she talks about one of the big prognostic things being high levels of pain and disability. Well, if you don't know what conditions in the shoulder are commonly associated with high levels of pain and disability, you can very quickly write somebody off within that psychosocial domain. But equally, if you know the things that do, it's going to highlight those who maybe those psychosocial factors, negative beliefs, whatever might be more relevant, and you're going to invest even more time in pursuing. So I think that biomedical knowledge base definitely is really important. And I recognize my bias because I work in secondary care, but I consistently see people who've been down the generic exercise advice, get yourself sorted. Now there's a lot around how that was presented, which no doubt was faulty, but they see us 4 or 5 years down the line and we do very simple things and they still get better. They get back to doing the things that matter to them. They don't fit that kind of profile of centralized pain or persistent pain. They've got a mechanical problem that just didn't get better. So I'm going on far too much, Jack, but I think, you've got to have that knowledge base. So I guess a key example would be, if we're saying that we're going to put non-specific shoulder pain or rotator cuff related shoulder pain or subacromial pain, whatever you want to call it, in the same group as non-specific low back pain, I can't argue with you as long as they hit the case definition for that group. If, however, you've got somebody who's 50, who's got increasing stiffness, doesn't have to be diabetic, but clearly is developing a frozen shoulder, they're going to have horrible pain. And if I tell them you need to exercise for 3 to 6 months and you'll be better, they're going to be really cheesed off at 3 to 6 months because they ain't going to be better or back to doing what they want to do. And there's other groups as well that might not have a traumatic history, but you've still got to be vigilant about, both in allowing you to set those expectations, but also the different options in terms of management.
Also, with regards to Rachel Chester's work, of course, for those that haven't listened to it, then me and Rachel did a podcast, I think, again, I keep saying a couple of years ago, and it'll probably end up being like 4 or 5 or something, time's flying. But in her work, one of the things that was clearly highlighted, especially in a really lovely discussion, although I think I've probably overindulged and maybe read her full PhD, I can't remember, but it definitely in there, she's recognizing that the disabling conditions or disabling features that can affect people, then it's going to matter what they're asking of their body as to whether or not that's truly going to be disabling for them. It might not be relevant. You know, someone who's got an occupation or a circumstance at home or age of children where it maybe doesn't matter for them to use their left arm for a bit, whereas there are some people's existences, be that work or home, that mean they can't. That's where that complexity lies, and that specificity that needs to come in, even if it's not tissue specificity, even if it's not that you need it to be really diagnostically accurate to, especially on a tissue level, the specificity that brings to bear their circumstances is hugely important. So I always find it funny, because when we even speak about non-specific shoulder pain, non-specific lower back pain, I always say that you're meaning tissue non-specific, aren't you? Because there's nothing non-specific about each individual person's circumstance and how it's affecting them. And like literally the size of their dog is going to matter. You know, that's specific. So it's tissue specificity that they're on about. But too broadly, they're actually meaning it's non-specific, and there's no relevant character to the individual in pain that would affect the prognosis. And we kind of know, and it's almost like the shoulder. There are more prescient examples of it almost in conditions than there are sometimes elsewhere in the body, which just feels like this is almost the thin end of the wedge to have this, hopefully, a bit more of a grown-up conversation about it. So that's why you're in the frame, mate, I'm afraid. What do you think in terms of the? Let's pick on an example of something that's then traumatic, just because let's make it easy on ourselves a second, and think that we know that someone that is otherwise well, that then presents with some trauma, that might have then a challenging objective assessment because of all the garden, etc., that occur. Even in our last podcast together, you made clear that done badly, then that isn't just let's err on the side of caution and give it a few weeks, because you might have missed your opportunity there. Whereas I think that's everyone's goal too, isn't it? Let's give my best guess and then review it at an arbitrary period of time afterwards. I can understand that feels safe compared to raise the alarm bells and send you to see a surgeon, granted. But in certain circumstances, especially on this trauma side, the consequences of that are devastating to an athlete.
Yeah, for an athlete, for sure. And I think what you highlight so importantly there is, in terms of shared decision making, it's about that individual context and about that patient. And if you look at most guidelines, it is absolutely about what matters to them, the consequences for them, and how they're coping and the impact that that's having. So that individual experience of that symptom. But again, I think we have to be honest, because if you take something like traumatic rotator cuff tears, we have this massive belief that, we need to repair them quickly. The evidence suggests that probably if you do it within 4 months, they're going to get a better outcome. But then if you drill down to the detail of all the traumatic cuff tears that present at accident and emergency, actually only about 40% go on to have surgery. So then the interesting thing as a clinician is the ones that go on to surgery tend to be the ones that have immediate pain, immediate loss of function, and that's not changing at 2 and 6 weeks. And that's where the evidence is really useful, because it helps you kind of signpost and inform your clinical reasoning. And equally, again, that structure is less associated with pain than psychosocial factors. So actually weakness, if you assess weakness and you can't change it, that's probably more useful in informing an early surgical opinion or an ultrasound or whatever than perhaps some of those other factors. And I think those are the nuances that we can't afford to lose. It's the same with a first-time dislocator. There's about 3 papers actually just come out at the end of 2020 looking at rehab versus surgery in the first time traumatic dislocator. And at the moment, there's still a trend that you leave it. But the 3 papers say the same thing, that early surgery gives an athlete the best chance of getting back and not redislocating.
Wow.
And, you know, and again, I think that's what, and I'm not saying you should operate on every athlete who has a first time dislocate. We know that's not necessary. But then it's okay. Well, then how do you build the story and what matters to the patient? And then the small part of your clinical examination to kind of prove or negate where you think that should be going. So, you know, I think it is clinical reasoning, isn't it? But making it relevant to the person in front of you.
I've often said that you can only reason with what you know to some extent, in that people sometimes will be bearing in mind their treatment options, following an assessment and trying to then err on that side of caution like I'm describing, whereby they're then thinking that, well, let's try something conservative and get stuck into some rehab for a period of time before thinking about more drastic interventional means. Really sensible MSK logic that I'm certainly not overturning in this. But if you've managed to think in that direction and you've tidied the edges of your thinking in such a way that you're then not really, there isn't really a case that presents itself whereby you'd really consider that surgical opinion a bit earlier than normal, or you're not considering other injectable options. If you've kind of blinkered yourself into thinking that that's going to catch all or catch so many that the few percentage that might need that, I'll find that out in a few months' time. I think that the missed opportunity that comes from recognizing the opportunities that those other interventions bring and early surgery brings to otherwise young athletes. I mention athletes just again, I'm trying to make it for once easier for us, whereby, you know, that first time dislocator that's then got significant structural change that then indicates earlier surgical intervention. It's something that I feel like to some extent, some people are almost cleaning that from that. They're not even reasoning with that jigsaw piece almost, because they've kind of convinced themselves that, much like the rest of the body, it's that, well, I've at least got this period of time to sort of play around with it. And if that instability doesn't correct itself, I'll pick that up later. And I think that there are proxies to other conditions there that kind of, where in that particular context, I would say the pendulum has swung away from structure, and even people perceiving in arguments online where people saying, well, actually anatomy rarely matters, and when it does, I'll think about it then. And they've allowed themselves to not be, they're going in that non-specific direction, even in those instances. And unfortunately, the circumstances that are around the patient can be quite catastrophic.
Yeah, it's funny because I'll answer that first, but then be devil's advocate, because I think that the thing with the structure is that there's absolutely no doubt that imaging in somebody who has a first-time dislocation that requires relocation, that wants to get back to sport, you know, particularly any contact sport, they're going to be falling over a lot. Imaging is very useful in forming decision making in terms of bony loss, in terms of the extent of that labral tear, etc. And there is good evidence to support the things that make you more at risk of redislocating, a hill sacks if it's on track, off track, whatever. So there are some structural features that are definitely worth considering if you're going to do true shared decision making. You've got to do that to have the whole picture. But and also there's clinical things like if somebody still has apprehension with that same history, and again, that's often the nuance that gets lost, that any of these things are only relevant with a relevant history, with the right injury and needing relocation. But actually, the kind of, if you like, being devil's advocate, and the caveat to that is, if you look at Margie Old's work looking at the role of kinesiophobia, and there was another paper by Eshoj, I can never pronounce their name, but essentially they were showing that whether patients were operated or not, kinesiophobia was one of the deal breakers. And Margie's obviously shown that in terms of kinesiophobia or fear of re-injury itself actually are predictors of being more likely to do it. So arguably there's still a case for investing in that 6 weeks of rehab and addressing a lot of those things that could stuff up the ultimate result. But what I love about what you're saying is that's got to be done in conjunction with the things that increase the likelihood of that athlete dislocating again. But again, you know, whenever I'm teaching, it's always that age mechanism, location of pain, how it behaves. Those things together are really useful. In isolation, they're not. And if you look at Len Funk's group, they've done some lovely work looking at young athletes going back to contact sport, and shown very clearly that actually, even if you operate on them, because they're still growing, they've still got a good chance of failing. So again, you kind of need to know these things, because if you're truly going to inform shared decision making, it's not just, oh, you're scared of injuring it again, so you're going to. It's like, well, you probably are going to, because you've got, you know, off track Hill-Sachs lesion and a 360-degree label tear, etc., with all that clinical information. So it's knowing all those things and putting that package together.
Well, it's remembering what the word, the suffix phobia means, irrational fear of, right? So it's helpful for us to try and tease out which are somewhat irrational. It's not meaning it as a slur, of course, that the person is rational. Obviously, it's their body being is what would be protective, be that whether that's smart or not. But generally speaking, that is a huge difference between an irrational fear of dislocating and a rational fear of dislocating. And teasing those things out sometimes requires imaging. And I suppose that people's rhetoric, they're so used to saying it, and often justifiably so. I've said it plenty of times, of course, myself, any given clinical week, where I don't think an MRI will inform our decisions at this point in time, but the moment it might do, then we'll definitely bring that back to the table. We're not saying never, but right now, I don't think it influences it. Whereas there are, because sometimes that's on the tip of our tongue, we're sometimes applying that to circumstances where it could really quite indicate a different path that might be taken. And I suppose I want to think about the why that might occur. You know, even if these aren't totally rife, and let's say we're not even making a case here, I guess, that we're suggesting this is the number one issue in MSK right now. But when it does occur, and I want to think about why it might, I feel like the specifics of the pathways, say, especially in UK healthcare, let's say make it in the NHS for the moment, in realizing that you often can't concurrently do that, whereby you've got this imaging, surgical, rehab opinions all in one, especially in primary care. It feels like there are thresholds that need to be met for that to be triggered, then a wait in each interval. And it's those sorts of practical aspects that make me feel like I want to raise this tentative alarm, is that when we're thinking that you can go through the motions in such a way, recognizing that when you think about it, we know how long it'll take for when you do pull the trigger on that scan. We also know the timeframes of that to come back through. We know the timeframes from that, if it does indicate surgical opinions, what that might be. And I'm saying this as we record it within a pandemic, but I'm even thinking far pre-pandemic circumstances which influence timeframes. I'm just thinking that if we've not been thoughtful in that first analysis, and we're not recognizing that those things are in play, then time passes. And then, of course, the person in the middle of this that could be in significant pain, distress, worry, the way that changes movement behaviors, the way that changes relationships, the way that changes their position within a social group, within a rugby team, right? These things, of course, we know have huge impact. And I think that the reason why time passes sometimes is because some therapists miss that, because when they send that letter, almost psychologically, they think the surgeon sees them next day. And I know they don't think that, but it's kind of that, well, we've tried this for a few weeks, and then if it doesn't work, we'll do this. But then without being thoughtful about how long those timeframes might be until they might take the scalpel that they do need, I think that's one of the reasons why. I just wondered your reflections on that pragmatically.
I probably have quite a biased opinion about that, because I think we've worked very hard we're lucky that we have specialist GP in the team who liaises with primary care. So I think actually there's less of an issue with somebody who's had a clear mechanism of trauma, because I think that immediately alerts clinicians. And I think, again, you know, we have the people who work with us within our team work in primary care clinics, as well as obviously being taught by us about the patients that are post-op after actually having surgery. Yeah. So they're kind of well placed to see that whole spectrum. So I guess my life is easier in some ways. And I would say that actually, in terms of that traumatic group, they're very good at picking them up. And actually, they're a group that actually it's sometimes harder to say, well, actually, yes, I know they fell over, but their symptoms didn't come on till 3 days later. So actually, the biggest issue you've got here is the belief. And it's a bit like that, it's a clinician belief as much as the patient. And again, I think it brings us back beautifully to that communication. I'm digressing slightly, Jack, but you said something that I just wanted to pick up on. That Lynn editorial that talks about patient-centered care talks about our kind of tick box communication. You know, you don't need a scan because there's nothing worrying, as opposed to, why do you think you need a scan? What is it that's concerning? And then when you've done your assessment, come back to it and say, well, look, the good news is there's nothing that concerns me. I can change your pain when we do this, or whatever examination technique I use, and then reflect that back to the patient. But again, with my team, it's often if somebody's really believes somebody needs a scan, it's like, well, why? Because actually the history you're giving me doesn't make me think that any structural element's likely to be relevant. So I think in a traumatic group, people's threshold to refer on is much less. But I think that the harder thing is the maybe atraumatics that might have had trauma a way ago that's just not been picked up. And those are the ones, though, if we don't hear that story accurately enough, we can get ourselves into trouble. Sorry, I don't know if I answered that question.
No, it does. Well, I think it's a good point, because I think there is almost a bit of an instinct difference there, or a sensitivity difference between us a little bit. And I wonder if perhaps that's something to do with the usual postcode lotteries, especially with regards to the circumstances. I mean, I'm not trying to justify. It could well be that I'm being a bit too cynical of the pathways there, but it just feels like potentially from, I know I haven't, funnily enough, I'm based in the Northwest now, but actually until we actually set this up, I haven't really done much of my career in the Northwest. So I know elsewhere in the country, I've found that the frustrations I've just articulated feel like they continue to perpetuate. Whereas I do know that in and around this area, we don't seem to make those mistakes as readily. Do you feel that there is there remains an issue with regards to disparities in care, changes and differences in pathways? We haven't seemed to come up with my bias is that we don't seem to have come up with a good way of blueprinting the good and trying to out the bad, really, and translating that across the country.
No, and but I think that's because we're still reflecting on what the good is and what gives best value. And obviously, there's a few trial, well, one due to be published that we've had the initial results of. There was the Roddy trial last year, and we're kind of almost going full circle. And I think, you have a study that says actually, if you just do an injection and advice leaflet, it's as effective as doing some one-to-one physio. And then potentially with the graphs that until we see the detail, we don't really know, but the soundbite seems to be 1 hour best practice advice session, if therapists are taught how to deliver that, is as effective as up to 6 sessions of one-to-one rehab. And as a clinician, that really kind of makes you reflect on, okay, well, what is really good? And I think there's no doubt, it almost takes us back to where you started, is there are no doubt some key things that seem to be influential in people doing well. And the key thing is to do something active for the thing that's an issue, do some better physical activity, but also do it in a progressive and meaningful way. And those are common rhetorics that you hear in everything, but are also massively important for patients, but also that they do it long enough. And if you kind of look at lower limb tendinopathy, they're advocating a year now before you'd kind of do anything else. And I think what's really difficult is in terms of what's best and those pathways, that traditional escalation from it, and I mean this in atraumatic shoulder pain as opposed to the traumatic group, is you don't get better, you might have an injection. If you don't have any, and that some of this evidence is suggesting maybe we should do an injection a lot earlier than perhaps we have been, because we've kind of really said injections are bad, let's not do them. And now we're kind of reflecting maybe that was silly. And then if injection doesn't work, we're going to do an operation, but we're going to do an operation that in some cases has been shown to be no better than placebo. And actually, if we're saying the issue, the deal breaker is the lifestyle factors and the psychosocial factors, what's the surgery doing? Giving people permission to take time out of their life, removing all those other stressors that have stopped them getting better. We don't know. There's so much we don't understand. And, I have my consultants are absolutely brilliant. The surgeons I work with are just so open-minded, but they are honest. They have their belief and bias system, but people do well if they select their patients well. And they will only operate on patients they are confident they can make a difference, because why would you do anything else? So they have a clinical reasoning process too. But back to your thing about pathways and what's good, there are some common themes. And I think what's so hard as a clinician is we're kind of being increasingly told it doesn't need to be individualized. That's actually not true. All those common things work if you individualize your communication from the outset and contextualize it in a way that's relevant to that person in front of you. And that's the thing that you've got to reflect in pathways, I think, and what's currently lacking, because it's all about, there's always shared decision making at the start of it, but then all the attention is to the interventions. Is that fair?
It is, and I think one of the things that highlights as well is that we had this phase of stratification being a big word that we used in MSK, and it's still around, but it's just that when people think that now, they think about an almost empirical style of stratification, almost like we're running some sort of algorithm that downstream of an initial assessment, then that's where it can be then appropriately pigeonholed or put into categories. Whereas actually what you're describing is something that, of course, we're always stratifying into various different things as part of how we're thinking and decision making that goes on. Now, if that is appropriately shared and there's appropriate intervals at different stages of that, that's true expertise. And that what we've kind of been allergic to some degree is because we've all been rightly scrutinizing our biases so much, we've then sometimes stripped ourselves so far back that we can't trust base instincts to make decisions, especially when you're then sharing that with a patient. You know, if you were dictating that, I think you're right to be doubtful. I think it's a good instinct to sort of always sense check yourself if you're having to advocate for someone else. But if you're truly engaging someone sensibly in a shared decision-making process, then there's something to be said for your expertise. You know, there's something to be said for your instincts there, and to articulate them thoroughly, even articulate them by way of referral or picking your phone up to your friendly neighborhood surgeon, etc. So you've got to then try and find a way to balance that out. Whenever we're talking about the general and the specific, I can't help but want us to get stuck into the term of diagnosis, right? The act of labeling. Always a fraught conversation all over the body, but in the shoulder, you know, it feels like that rumbles on. What's your sort of take on the necessity of diagnosis in various different cases?
Yeah, I love that question. It's funny because one of our band sixes came up to me and said, "Why do we call it rotator cuff related shoulder pain?" I was like, "Well, you can call it whatever you want, mate, as long as it directs a path of care."
Yeah, who's we? Why do we?
Yeah, exactly. Yeah. It's not my fault. It's Jeremy's. But I think Jeremy, really, when you look at what he's done to challenge practice and really get us to reflect on the goods and the bads of what we do and how to do it better, the whole point of that was to get away from a term impingement and to try and come up with something that had more positive connotations for patients, in that, we had research saying 70 to 80% relates to the cuff or the subacromial space, however specific you want to be. And so a term that basically suggested that actually, if you work on those muscles, you've probably got quite a good chance of getting better. But I absolutely understand people would criticize that for being too tissue centric, and say, oh, it should be just subacromial pain or non-specific shoulder pain. But as clinicians, we all know that if you sit there and a patient says, well, what's the matter with me? I want a diagnosis. And you say non-specific shoulder pain. And what you mean, you don't know what's the matter with it? We can all give those examples. So, for me, the important thing, whatever it's called, is it directs a path of care and means everybody's clear what needs to happen and how long it needs to happen to give that person the best chance of getting back to the things that matter to them, but also importantly that they're educated how to deal with that. So, I always feel like I give such a politician's answer for this, but it's true in that I always ask patients what they've been told before, because I very rarely see anybody as the first person. They've usually seen at least 2, 3, 4, 5, sometimes 6, 7. In fact, one guy, 73 practitioners before they got to me. So what I want to ask them is what do they think, or what do they understand about what they've been told? And what's not an uncommon story is they'll say, I don't really know, or I don't understand, or I was told it was impingement, so I don't understand why I haven't had any surgery, or I was told it was this and I don't understand why it's not got better with physio. So the narrative is very dependent on what's happened to the patient before. And if they say, oh, I've been told I've got impingement, my next question is, rather than go, oh, we don't call it that anymore, is say, well, what does that mean to you? And if they say, well, that means I need to do physio and get my muscles stronger, then great. And we can challenge that narrative, but they're already on board. Whereas if I have somebody who says, well, it means I've got a bit of bone that needs chopping out, and so I don't really know why I'm here, as per the lovely Andrew Cuff's work, then that's a very different conversation. So it's a bit like I said about the imaging. I'm going to ask, well, what does that mean to you, or how do you feel about that? And if they're really set on that model, I'm going to do my assessment, see if I can influence things, and then reflect that back at the end. It's much easier if I can change things, because then I've got a kind of like an educational behavioral experience that's challenged those expectations, and then go back to, if you like, put a more positive narrative that doesn't place surgery as the first option, I guess.
That's it. No word is ever context independent, right?
No.
Of course, it can be when written on a page somewhere, but it's more in these instances, in clinical encounters, like you're describing. If it's not the word impingement that's inherently dangerous, right? It's not, there's something about those syllables or how it's understood, and so there is something that sounds quite mechanical. You see, and it's funny, you can almost correlate that across occupations, can't you? Often, if you've got an engineer that's been told they've got impingement, they'll then come in with some sort of either drawn it or they've rigged a diagram or some sort of model to think that what's being pinched, what needs to be adjusted mechanically, and they can understand why, because it has that language to it. Whereas actually
Absolutely.
some people, it's just not that. They don't even care. They've not created any imagery around it. There's no nocebo effects to it. They don't really
They've got
give
a label.
Whereas if we got stuck into them and said, well, let's put that right, let's take that word out of your mouth and correct it with one of these other acronyms, then, you know, what are you doing? Who's that for? You know, is that just to settle yourself?
Yeah, well, and you know, it's interesting because if I look at our pathways are just subacromial pain. And the only reason we didn't call it shoulder pain is because we've got to delineate it from frozen shoulder, calcific tendinopathy, so we want to delineate it from groups that may have a slightly different path or a higher vigilance to refer on and stuff. But I absolutely agree. And I think, you know, as clinicians, we're all lovely and we're kind of set to want to help and make things better and educate. But, you know, actually, often patients are pretty sensible and they've got quite a good model. So if you actually understand what it means to them, and if they're happy with that, just, you know, fine, just go on your way. It's only when they're not happy or it doesn't fit with their belief sense and they can't make sense. So that sense making is just so important in taking them on that journey with you.
Yeah, absolutely. I mean, I just to be clear as well, for anyone that hasn't listened to some other shows in which I have admitted to not just staying on the fence on it, I'm a fan of subacromial pain or SAPS as a point where it's not making tissue specific claims, but it's also given a region and also is then known to be categorically distinct from frozen shoulder or other more specific traumatic tissue related things, including cuff tear. Of a relevant traumatic origin. So I admit, and I said this, I think, on the podcast with Rachel, and even years back with Jeremy on an podcast, it was kind of that, you know, really, I think that's best of a bad bunch in many ways, but we're in a situation where it only matters when it matters to a patient. We needn't get too stuck in the weeds, I don't think.
Well, I agree. But I think the other thing that we have to be really mindful of, and I mean, again, you know, we've talked about so many important things today, but if you look on, you know, I did this last night because I knew I was speaking to you today, and I just went on Google and I put in shoulder pain, and what comes up? Bursitis, impingement, rotator cuff tear, tendonitis, you know, and we're all like poo-pooing, oh, that doesn't work. There's a lot of healthcare professionals still use those terminologies. And what we don't want to do is make life, if you disagree with a trusted healthcare professional the first time you meet somebody by saying, oh, don't call it that anymore, I'm so much cleverer than them, we've lost the patient before we've actually started. So I think you're absolutely right. It's context and what it means to them. And as long as they have a positive narrative, then why change it?
So when we think about, and we're describing, I was saying about why some of these issues might emerge, I feel like one of the disconnects that's occurring is that, and we can keep us finger close to the pulse of ascendant contemporary MSK practice in whatever body part, and also these overarching themes that we've talked about and noticing. But then also you've got to keep in touch and keep your fingers somewhere close, if you can, to the pulse of what is the mean? What is someone somewhere in the country or the world getting when they then, or what they're hearing when they then present with pain to an MSK professional? Because sometimes those are two very different things. And actually, if we overindulge one, then we'd suggest, oh, things aren't changing. But if we overindulge the other, then you kind of get lost from what is the reality. And the patients, especially when they're then, you know, second opinion and beyond into 73, did you say? Then their story has been hugely coloured by those interactions. And I feel like that's something that we've got to keep an eye on. And I think that that's one of the things that social media has done for ill, really, is that sometimes the gap between those clinicians that are paying attention to every latest release, be that research or podcast or otherwise, and those that aren't, unfortunately, that gap is not something that only affects clinicians. It broadly affects society, and we can become disconnected between what reality is in practice.
Absolutely spot on. And I think, you know, when I think there's a couple of things. I think if you look at I can't remember when I said it, but I said something about communication being a superpower and stuff. But the bottom line is, if you get it right the first time you meet somebody, you engage them, you contextualize their pain, you hear their narrative, and you reflect everything back within their narrative and set goals that matter to them. And Tamar Pincus talks beautifully about affective and cognitive reassurance, and that, you know, you can be all lovely and empathetic during listening, establish that narrative, but at the end, when you give them it, they want a clear diagnosis, clear options, and positivity. They want optimism. So they want a positive prognosis. So somebody with a first time shoulder pain that I say, look, it's great news. The majority of people with this get a significant improvement within 3 months. We know that. if you don't exercise, if you don't do this, it can take longer, but there's lots of things that you can potentially do about that. But it's all about inviting the patient about what they want to know and what's most useful to them, because I'm not going to throw all that lifestyle stuff at them if they're not ready to hear it. But a lot of the time patients will say, oh, well, I wasn't sleeping as well and my pain was really bad, or I was really stressed at work and my pain was really bad. And so would it be helpful? Well, what do you think about that? Well, when my stress is worse, my pain's worse. Well, would it help to understand that? Because then again, within that biopsychosocial framework, it's easy to signpost for patients. So it's not like you're there saying you must do this. In fact, I loved Pete at your 3Rs thing when he was talking about being the chauffeur and doing it all for patient. Pete Moore, I love that, as opposed to being the coach behind them on the bike, kind of guiding, supporting and giving them the knowledge. And that's what your job is, but within that patient narrative. So of course all those things are important, but it's contextualizing it in a way that's got meaning for them and their goals, not ours.
Yeah, absolutely. I think what I find fascinating within that is if we can't get past that, and we can't recognize when we might be leaving patients behind for what is actually an academic into clinician aspect, then we are overindulging the academic and the intellectual, and forgetting that the whole point of our role is to help people in that, on that journey, and help as many people as we can on it. And I think that that's something that what you've described there really speaks to. I wonder, when we're trying to navigate that space with the lifestyle variables, it's like that's where it becomes really complex, because sometimes those are natural triggers to people that are very personal, independent of their injury, especially if it catches them off guard and they see it as being a massive leap, especially with regards to things like weight and smoking and activity levels. There are things that people feel like, oh, blimey, I was irritated when someone mentioned that was one of the things my skin was struggling with. But now you're suggesting that this mechanical, they've perceived it to be a structural mechanical problem, that they just think, what an incredible leap for you to be making to accuse a variable like that as being causal. And so I always said there's two easy options there. You've got some clinicians that then will happily and quite bluntly just infer that is a causal reason for non-recovery, if not a causal reason for their pain. And then you've got those that then just dodge it in every which context, right? And I always say that, unfortunately, like I've little sympathy for those that are just being rude, and those that it's like, whereas you've got to have an ounce of empathy and compassion there, and recognize that and unfortunately few and far between in all games. But then also, admittedly, I can get why you might dodge it, but also the jury's not out on this. It's something that on some of these things, it's actually really remiss and not a caring thing to do, to dodge it because it's awkward. So obviously, as ever, we're trying to wade through the middle, but I don't think I've recognized that no matter how long in time I'm practicing, I find it still very difficult to navigate that space. I mean, I wonder if, unless you have any pearls of wisdom, has it got any easier?
No, there's still times I bail out till the next time I see them, because I just think I've got to build this relationship a bit more. They're not ready for this, and I think there's, behavioral change in itself is a whole different specialty. But I think what was interesting about the GRASS trial, and what will be interesting when the detail, because they're going to produce resources to help clinicians, is what that education was, because it was only a half day or a day, and yet it seemed to make a big difference. And I think what you've nailed is that clinician confidence, because if you look at what patients really value, somebody who sounds like they know what they're talking about, they're confident, they're competent, and they're interested in that individual and optimistic. Those seem to be things they really care about, and lots of positive nonverbals, all that kind of stuff. And I think, for me, I've said it a few times, but I think where my communication style changed dramatically after I'd done my communication module was I was always trying to fix, I was always trying to give knowledge, I was always, as opposed to that very getting the patient to reflect. Because patients, when they come to us, it's why now. It's easy if somebody's done too much in the gym and got a reactive tendon. It's easy if somebody's fallen over and hurt something. But what about the person who can't give you any mechanism of onset, who is just an atraumatic shoulder pain? Why now? What has tipped things over, whether it's in that biopsychosocial domain? And so what's going to be the thing that makes the difference? And of course, I still do my clinical examination that informs my exercises in all those patients. But at the end, the conversation I will have will if I think those things are really relevant, will reflect it back, but not in a judgmental way. But or sometimes, even though we're not meant to do this, I draw my 3 circles or Greg Layman's bucket or whatever and put in all the things they've told me, and they feel heard. But often they'll say, oh, is that why when I'm stressed it's bad? Or, I did feel a bit better when I lost weight or whatever. And they'll often signpost that for you, but it's giving people the time and the space to do that.
And that's the thing as well, is helping them to understand that there's sometimes hearing, if it's done badly, and I'm not meaning because I've witnessed it done badly, I've done it badly plenty of times, is that you word it in such a way that they think you're inferring that is particularly causal to the onset. Whereas a lot of the time we're usually as therapists saying, it's one of the features that might stall or stagnate your rehab, which so when you're wanting to move things optimistically, there's that secondary thing, really. It's why we can't change that might have happened, but generally, if it's gonna, what we understand, especially low-hanging fruit for me here would be, say, tendons and smoking, and or sort of obesity to the point of, say, adipokines and the variables that we think might be influencing those sorts of things with pain sensitivity. You're kind of in a situation where it's like, well, that's somewhat been, and so therefore it's no point in having a conversation. It makes you feel awkward by way of punishment. Instead, what we're talking about is that these are variables that will mean that this process, that unfortunately isn't a click of a finger process, it's a rehab process, is one that will be enhanced by a movement in the right direction of these things. And I think that's sometimes, if you can explain to folk that it's not that you're making accusations or trying to infer cause, you're actually saying that these things will actually help, or we hope help, your recovery. It's a more optimistic thing, gives them more incentive, doesn't it?
Absolutely. And I think I always talk about shining a light on them, shining a light on their individual experience. And often they'll then say, well, I've been meaning to lose weight, or I've been meaning to give it. Why do you find it hard? Because then again, it's all in their narrative. It's not us trying to offer solutions, and then finding the support that they need. There's a great website, actually, Moving Medicine, and that has a whole thing about difficult conversations around weight, around smoking, around lots of different things. And that's definitely a resource to have a look at. But as I say, I think there is no magic script. I really believe in that shining a light on all the things a person's told you, summarizing it back, the things that are relevant. And actually that often then makes that conversation much, much easier to have.
Absolutely. Now, hanging over these 2 things, and I'll bring us somewhere nearer the end zone here, Jo. But I think that one of the things that brings us over that kind of looms over a lot of this and influences it all is this notion between statistical empiricism as aspiring to a narrow sense of what research is driving towards in terms of facts of the matter. Almost, can our interventions be delineated like pharmaceutical trials could, and things like that. And then you've got this sort of mother knows best style of assumed wisdom that's sort of a kind of just passed down oral tradition. I'm caricaturing, of course, here, of anecdotal practice, right? But that tug of war and that spectrum, and call it what you will, that goes on, is something that we don't want to be by those poles. What's your take as to what is on the ascendancy at the moment? Is it crying out for niche anecdotal style practice, or is it that things are being rigidly made empirical and people are needing to be categorized?
Oh, that's such a great question, Jack. I'm not quite sure how to answer it. I think we've been through the whole stratification of care, and we found that it has limitations. But I think when we look at diagnosis specific, I think as ever, there needs to be kind of more link up between clinicians and research. I think it's happening better, but I think often for clinicians, when we get things coming out that seem to undervalue our interventions and say that actually we're not needed and people can do it on their own, it's very easy to feel under threat, as opposed to actually making healthcare more sustainable and actually giving us more time to spend with the people that really need it and smooth out the pathways and make other forms of care more accessible. So I think that hasn't answered your question at all. But I think for me, it's the evidence is really important to shine a light on what we're doing, but we also know how long it takes to get into practice. So for me as the clinician now, what can I do better? And for me, the overwhelming message is understand the individual in front of you and what matters to them, but have a robust knowledge base that allows you to be confident that there's nothing serious, nothing that you could do something about to help that patient get back. And there are some key ingredients that seem to work for the middle ground of patients. However, there's 20% of patients that will need more investment in those pain beliefs, etc. And there are definitely patients where having a structure of exercise seems to have some additional benefit. But I know what I do and what works for me, and lots of people say what works for them. But the key themes are it's progressive, it's meaningful, and it resonates with the patient's goals. And those to me are where we're at. And I think as clinicians, we should feel empowered and not feel threatened, but just use it as a way of reflecting on what we're doing. Sorry, that was I don't know where I went with that, Jack.
No, it's a great answer, but I'm also going to be a swine and sort of try and press you.
So you didn't answer my question.
No, I'm not. It's more that if I had to pick, so I'm going to try and design and see if this works, especially if we're doing this in Awana. Let's see if we can manage it. But there's two sort of examples I want to try and give and sort of force you to pick one, even though you might not like either. But in one case, we know that what you've described there in your answer is that the interface for care delivery is of the clinician, and therefore the evidence is going through them. It's not as if said research can treat the patient, right? We know that's, I know it sounds silly symbolically, but generally speaking, it's going through a human interface that is the clinician, and therefore it's being transmitted and hopefully shared with the patient, etc. So we're bringing values, we're bringing our philosophical priors, right? Let's not be ignorant enough to think that true empiricism would work until the robots are summoned as our replacements for that. But generally, if I was to then think that in one instance you've got the evidence base in all its richness, not just meaning the statistical literature, meaning that all of that and all of the things that might influence decision making being then moved through clinicians, and then trusting clinicians through an education process and synthesis of that, an organic synthesis of that, making those decisions with patients is my one example. And then another is that evidence, all of which, including your statistics, is doing that, but then simultaneously parameterizes service provision and policy in such a way that then narrows the scope of which that clinician could do things. And now I wondered if I was to think that, because in this instance I've just characterized it in those two, where do you feel you are in terms of if you had to pick one or lean towards one or the other of those, in terms of how much should we trust clinicians to have a full suite of everything available to them, and how much should we parameterize that extent?
Oh, Jack, that's a hell of a question. I think the sad reality is we're driven by cost effectiveness. And in fact, interestingly, a guy on a course said, oh, well, this is just all about costs. And I suppose at the forefront of the NHS, in lots of ways, it is, because if you can't prove superior quality of doing several interventions over one really good 1 hour session, then that puts us in a difficult position. But then I think where the nuances get lost and what concerns me is almost back to where you started, is does that mean the person that's not good enough for then disappears, comes back 6 months later and is harder to help? Yeah. So and I think that's always the trouble with the research, is that middle ground. And obviously until we see the data and the confidence intervals, it's very difficult to comment. But I think for me as a clinician, to not be able to make that decision and only be able to have that one session, I know in any study that looks at first time shoulder pain, half of them are going to be better anyway, irrespective of what we do. What matters is, I also know that 40 to 50% of the people that get better will have recurrence in 1 to 3 years. So has that one intervention been enough to sort that out down the year? Because again, if we look at all the evidence that supports our therapeutic alliance, and that some people do need something additional to exercise to get them on that journey, I want the autonomy as a clinician to decide that. And I've been incredibly lucky with my managers in that as long as our stats even out, she trusts us that we identify the person that does just need one session of advice and be reassured, because we know how powerful that can be. But also that gives me the freedom with the patient that needs 4, 5, whatever, to do that. And that's a model of care that I'm proud we've got, and I hope we'll be able to maintain. So again, I haven't answered your question, but well,
I thought you were going to have done a hell of a good dodge, but actually you did end up, I think, answering it. You would prefer the format. You made a case for that freedom to not be abused, but that freedom.
Yeah.
So I think because that's the middle ground, is that it's still monitored and accountable, but it's not parameterized arbitrarily. I suppose your example of amount of sessions is a perfect one. And in my second example, I would be saying that there is a literal mandate on the department for a certain amount of sessions per person. That would be a difference. And so, yeah, I thought at first you were going to go, but you didn't. No, I think you came to answer it.
But I do think, before anybody gets too excited and says, "Oh, but you should only have one session," I work in secondary care, so even though I am the gatekeeper, if you like, of what comes in from primary care in our MCAS clinics, I see my biases, and why I would say that is because I see the effect of people who not just had, because it can be very effective for some, the injection, the exercise sheet, the no intervention. And whether that's cultural, whether it's social, their expectation was not met, and and now their narrative wasn't challenged in a way that allowed them to get their life back. And so I think there has to be an element of flexibility, because otherwise those patients become massively resource intensive for the NHS when they don't need to be.
Back around, yeah. Well, and they just feel dismissed. Like, it's just
exactly.
Very inhumane thing for people to feel dismissed at their most vulnerable. It's just very.
But then what's empowering is if when we see the results of these studies is if you invest more in educating clinicians about the communication and that sell and how they give that information, then that's potentially exciting.
And we all know that they're the patients that we don't see, and you don't see, fortunately, because these are the ones that we know. We all see each other's failures or see our own failures come back around and stuff. So yeah, that's the context that we place it in. So yeah, I appreciate that, and it's been really interesting to sort of to really go into the details of this with you today. Could you just point people in the direction of where they can find out more about you?
I'm just putting a website together at the moment, Jack, because I've been so bad at doing that, but basically just as a central place for resources and about the courses. Twitter's probably the best place in terms of the courses that I do. I've got I still don't know why I did @ShoulderGeek1, but it's fine. I was very naive at the time. And then I've also got my online course with Clinical Edge. So those are probably the easiest places to find out about me.
Brilliant. Well, I tell you what, as soon as someone else turns up and could even challenge for the mantle of #1 shoulder geek in the world, then you'll have to hand over the handle. But actually, I think it's perfectly appropriate. I don't know why you're being so sensitive about it. Thank you as ever. Really appreciate it. Always enjoy this on and off air. And these sorts of topics, wading through the grey areas together is something that I really enjoy. But also, it's one of the things that if we can't find ways to articulate our positions on this stuff, then I know it sounds a bit dramatic, but it's the extremists that win. If we don't find ways to sort of navigate the complexity, then definitely those that are sort of nihilistic, narrow empiricists, or those that are just maverick wizards that are inferring that anecdote wins because they've got magic hands, they're the people that are going to win the argument if we can't find ways to maturely come through, not just the middle, not just sit on the fence, but describe that nuance as thoroughly as we can, which is why I think Jim came up with this idea, and I hope we've done it justice. He'll soon tell us if it doesn't. But thank you so much as ever for your time. Hugely appreciated it. And as per usual, I'm just going to tie you to one last cheesy sign out, if that's okay.
And that was session 86. Absolutely delighted with that, and we were both a little. I don't know if Joe will admit to being nervous. I certainly was a little bit, which is not an emotion that I don't think either of us are used to feeling. We're fairly okay with these sorts of bits and pieces these days, but that was a very novel thing we were coming at rather than a clinical topic. It was hard for us to prep for, so we just needed to sort of throw it out there and see how it went, and it was absolutely brilliant, fascinating conversation. Hope you enjoyed it. If you want any more like that, and you want any more thinkers that we explore that with, then please let us know. The practicalities of being a clinician these days and navigating a complex space, and the patients that are bringing ever more complex situations and presentations, is something that we really value, and bringing out material that supports you in practice. And that's the heart of everything we do. And so making sure we create material that supports you is vital. So let us know if you want any more like it. Any comments and feedback on this episode, of course, massively valuable. Please like and share the work we're doing on social media. You can imagine it's a congested market, and we're trying to continue to be what we're considered, which is the gold standard in this sort of thing. But also, please rate and review us on. We rarely shill for rates and reviews and stuff on your podcast providers, but it is increasingly valuable in a congested market, and we don't typically get people doing that. So please, if you don't mind, rate and review us as you see fit on your podcast providing apps. And hopefully we'll see you soon for more Physio Matters. Do check out the things that I mentioned in the intro if you didn't listen to those, be that Physio Matters Plus membership for locking in your low fees and low rates. for premium content. Pelvic Health Therapy Live is coming up on the 6th of March to get your ticket for that, which is free of charge, still unbelievable. And my little exclusive that I mentioned about these fancy dynamometer, accelerometer, goniometer, £300 unbelievable piece of technology that I'm going to get a couple hundred units for, that I want to get into your hands as exclusive. They're going to get snapped up quickly. So if you're listening to this and you want to get on that early list, then drop us a message, be that through DM on social media, email, whatever, however you can reach us. We will eventually put a catch point up for how people can do that. But if you're listening to this, that means you're our favorites. And if you want to get that exclusive, then get stuck in and just get in touch with us. We want to hear from you. That's enough for me. I'm fortunate that Jo, experienced Physio Matters guest, she got stuck in straight in with the cheesy sign out. So obviously I don't need to do it this month, but thanks as ever for your time. We'll see you next month.
This is Jo Gibson on the Physio Matters podcast, because physio matters.
Brilliant. It means that I don't have to do that. That's helpful. So nice one. Thanks a lot.
I nearly forgot, Jack. I was like, what am I meant to say?
Thanks for that.